Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am thrilled to be joined by my guest, Dr. Vincenzo Recine. Dr. Recine has his PhD in physical therapy and is also a certified functional manual therapist, certified athletic trainer, certified strength and conditioning specialist, corrective exercise specialist, and level 1 BPPTS certified therapist. He is the founder and owner of Prime Physio with locations in Bronxville and Mamaroneck, New York. The focus of his practice is one-on-one care using advanced manual therapy to work directly with patients' musculature and joints to restore movement, followed by neural re-education to help patients' bodies learn more efficient movement patterns. Dr. Recine and his team pride themselves on an approach to care that looks at the patient as a whole person, not just a collection of their symptoms. And using this information, they create personalized treatment plans for pain relief, TMJ discomfort, and sports performance. The secret to Dr. Recine's success is performing comprehensive evaluations of patient movement patterns to determine the factors contributing to their pain and dysfunction. They then use this information to create personalized exercise plans, which take a holistic approach to pain relief and healing, with the ultimate goal of helping patients return to peak performance. During today's show, we're going to discuss Dr. Recine's unique and whole body approach to health and wellness, including his diagnostic and treatment protocols for TMD, as well as the role that physical therapy can play in airway management. We'll get into how physical therapists and dentists can actually work together to enhance patient care and improve treatment outcomes, as well as what all dental providers should know about the integral role the orofacial musculature plays in malocclusion and TMD. Additionally, we're going to discuss strategies that all of us can employ to remain healthy and pain-free in our everyday lives, especially those of us who sit chairside with their heads down or at a computer all day. So without further ado, let's get on to today's episode with Dr. Vincenzo Recine. Enjoy the show, everybody. Welcome to the Doc Podcast, Vincenzo.
Thanks for having me, Mike. I look forward to the conversation we're about to get into.
Same here. Very excited for this conversation. Little bit different. People might be listening to this thinking PT and orthodontics and what do they have to do with one another? But again, my podcast is not just about orthodontics. It's really about overall health and wellness, not only for our patients, but for ourselves. And you fit right into that. So before we dive deeper into more in-depth content and conversation on this, tell me a little bit about your journey. How did you get to this point to become a PT? There may even be people who don't even know how you become a PT in this. You do have your doctorate in physical therapy as well as a bunch of other certifications in training and strength and conditioning. So you can take it as far back as you'd like to give the audience an idea of how you got to this point and where you're at now.
Yeah, so I actually never wanted to be a physical therapist until I got hurt. And, the first PT I went to was kind of like an in-network setting, didn't get that much personalized attention. And I was like, this is definitely not a career I would take. And then I met a woman named Jean Morganti who had a practice very similar to mine, one-on-one, 1 hour long with each patient, could really give her undivided attention and specific care. And I'm like, okay, how can I blend, not sitting in front of a computer all day and helping people? And those were two interests I had. And she kind of, brought that to life for me. And it's like, all right, this is a perfect fit. So I went to undergrad. I got my athletic training degree, which for those of you who don't know, if you watch sports, the person who runs on the field when someone gets hurt, that was me. And then I went straight into PT school from there. And then I met Brad Gilden, who owns a practice in Greenwich, Connecticut. He's a physical therapist in the Airway space. And he mentored me along with some of the other therapists there, and then introduced me to Dr. Michael Gelb. And I would shadow him sometimes twice a month, sometimes once a month. And I saw that there was a huge need for patients who have jaw pain, headaches, migraines, face pain, ringing in the ears, difficulty with vision, and how it's sort of all intertwined. And my background was so heavy in sports, and I'd even worked my way up to professional sports, and it didn't seem as rewarding when you see these people who are like so crippled by their symptoms. A lot of people don't know this, but TMJ pain is the second leading cause of pain in America behind lower back pain.
I didn't know that either. I didn't know it was that high. I would have guessed top 5, but I wouldn't have guessed 2. That's amazing.
Yeah, number two. And we spend a lot of time and we spend a lot of money. You know, I think the estimate was somewhere around $4 billion. We estimated in 2019 that was spent on treating TMD symptoms. And there was a study that came out of London, I think it was about 5 or 7 years ago. And so that the average amount of time that someone is in treatment for TMD symptoms can be up to 109 months. That's the average. So that means it's even higher than that. So it's like, you see the need, you see the lack of care that there is. And I was like, oh, this seems like something that, you know, I can fit myself right into. And then I just started taking more coursework, started shadowing more dentists, started lecturing at local dentist clubs. And it fit right for my personality. I was having fun learning about this. We didn't learn about any of it in PT school.
I was going to ask you that. Okay, interesting.
When we had 2 lectures, I was like, oh, that seems interesting. And then I forgot about it. And then when we started shadowing Dr. Gelb, I was like, oh, wow, this is very cool. And our manual skills can have such a huge impact on these patients. So that's when I was like, all right, I'm gonna, you know, dive head first. And then just luckily, I actually really, really enjoy it. I would say 80% of my caseload now is patients with jaw pain, you know, disc dislocations with and without reduction, face pain, headaches, migraines, stuff like that. And then I still treat my like typical ortho patients, my low back pains, the knee pains. Those are fun, but I definitely enjoy kind of, you know, being the missing link in the providers side of it when it comes to someone who has these symptoms. Because even nowadays, like myofunctional is still so new, you know, myofunctional therapy is so new, physical therapy is still so new, vision therapy is still so new. And being someone who can kind of be like, all right, I think you might need this in your care, or you might need that is fun for me. So that's kind of how I got into the Airway space.
That's really interesting. So it was before Airway even, it was a little bit TMD, orofacial pain, and then Airway kind of evolved as part of that, because we all know that tends to be related a lot of times.
Correct. Yeah. I mean, it's, you can't have one without the other, right? Like if you're coming into me complaining of jaw pain, I'm going to ask you how your sleep is. You know, I'm going to ask you if your partner notices it. Are you snoring? Are you waking up with a dry mouth? Like all those questions come into play here, because we all know if the sleep's poor, you know, our outcomes are going to be poor. So
well, we just on that, would you guess, top of your head, doesn't have to be an exact number, but if you were to estimate the number of patients that come to you with jaw pain, how many of them have a sleep-related breathing disorder up to the level of OSA, would you say? Percentage, sorry, so not how many, what percentage?
I would say probably north of 60%.
Wow.
Yeah. Wow. I wouldn't say I probably wouldn't even say as high as 80. If you were to ask me how many of them have some sort of sleep related issue, whether they're waking up multiple times in the night or they feel daytime sleepiness, they don't feel ready to get out of bed, like all of them have at least one issue. Like no one comes in here and is like, I'm sleeping 8 hours, I'm sleeping through the night, I'm not waking up to urinate, I'm not waking up because my mind's racing. I feel great when I wake up. I'm not having, 4 cups of coffee. So to me, like when someone tells me like, I'm having 4 cups of coffee because I don't have enough energy to get throughout the day, your sleep's not good, So like, it almost feels like my practice is evolving from, do you have OSA or sleep related breathing issue to how's your sleep period? Right? Because that's all going to affect your sensitivity to pain, and how well you're healing. And beyond that, kind of if you listen to Peter Attia or read his book, like Medicine 3.0, it's like, it's 2025. We should be talking about how well you're performing, not just like, can we just get you out of pain? So that's kind of like where my line of questioning is evolved to in terms of, things like that.
Yeah, that's cool. So we'll come back to the Airway and more specifics of Airway and TMD and diagnostics and treatment in a bit. Before we do that, I love what you just said about Peter Attia, and actually my talk at the Pandy meeting was Ortho 3.0, talking about highlighting this, how we need to take orthodontics to that 3.0 stance. And for everyone in the audience who maybe isn't familiar with my lecturing on this, as well as times we've spoken on the podcast or spoken about Peter Attia in his book, in Outlive by Peter Attia, he talks a lot about Medicine 2.0 being this traditional Western medicine. It started like early to mid 1900s with the advent of penicillin and these magic pills and things that could all of a sudden do things that we just couldn't do before. And it evolved into a very treatment focused, reactive approach to healthcare. And he calls for us to get to the next level, which he feels is what he refers to as medicine 3.0, which is this state of healthcare where we think of health span, not just lifespan. So instead of just keeping patients alive longer, keeping them, as you alluded to, healthier longer, and not just being reactive in our approaches to treatment, but proactive in trying to prevent the breakdown. I draw an analogy to that in the orthodontic arena as well. Clearly, you're drawing an analogy to that in the physical therapy arena. So how do you do it differently? So if you were to say versus a traditional physical therapist or the way that maybe you were trained to practice coming out of school, what is that difference that you take that is more in line with that sort of 3.0 approach?
Sure. I think it's a great question. And I think my athletic background is definitely what kind of set me on that path of like, okay, first and foremost, you need to be moving your body. There's, your body is not going to be healthy if you are not, and I know we throw these figures out like walking 10,000 steps a day or
right
along those lines, but it is good in a sense because it gives us some sort of goal or something to hit to keep our body moving. So for me, I'm looking right out the bat, like how strong is this person? Do they have any muscle mass on them? What is their movement practice look like? Are they a bodybuilder or are they just, a desk jockey who doesn't move all day? So I think that kind of sets me up where in traditional PT, as it pertains to the head, neck, and jaw and face, is everyone so concerned about like what's happening with the airway or what's happening with the teeth or what's happening with the neck? And it's like, they're still a human being, right? They need to move first and foremost. So having that knowledge and strength and conditioning background where I could say, don't worry about the weights. Like you can get plenty strong within your body. You need to be, move like walking this much a week so you can hit your cardiovascular numbers. And then you also need your X amount of strength training so you can actually build the tissue that supports the system. Because at the end of the day, if you don't have muscles underneath the neck, everything above it's going to struggle a bit, or your mouth and jaw are going to compensate for that. So I think that's, one thing that definitely sets me apart from someone who may be looking at the airway in a patient who's coming in with jaw pain. The second thing is just time, right? Like I have my patient for 1 hour, one-on-one. So I get to really go back in their history and really dive deep into like what may have caused this. I just evaluated a patient that was referred by Dr. Gelb, and her symptoms I actually told her when I was treating, I was like, I'm getting on a podcast with an orthodontist who did a really good job, which kudos to you. That's why I was so attracted to getting on your podcast, because you stood up there and you're like, these are the things I messed up. Like I'm not a perfect provider and neither am I. I have my fair share of mistakes. And I was mentioning to her because 7 years ago, she saw a dentist who shaved down her teeth and really drew in her bite. And my hunch is her tongue stopped sitting at the roof of her mouth, which created a lot of downstream weakness, which is now manifesting in headaches and migraines and so on and so forth. So I had 30 minutes, in my eval to really get back to the root of why that happened. Like, why did this woman's tongue drop? Why is it not sitting at the roof of her mouth? Why is she so weak? Why is she not gaining muscle? Diving into her diet, diving into her sleep patterns, diving into her exercise routine. Time is key in that regard, and it doesn't take a genius to get into those aspects of the patient's care, but you need the time to do that, and not everyone has that. So that's the last second thing. And then lastly, I was trained through the Institute of Physical Art, and they really do a good job of teaching clinicians how to harness the power of their hands and learning how to really fine tune where there's a problem, right? Treatment is as much of an art as it is a science. And I know nowadays everything's kind of going evidence-based, and you see in some arenas we're even taking a step back, like, okay, evidence is important, but so is experience and so is feel and so is the art of treatment. Not everything is 100% broken down into a randomized clinical control trial. We have to use our intuition and our logical clinical reasoning. They do a good job of kind of blending the two. So when I see someone who comes in with an issue, they helped me refine my hands to really, the restrictions here in the jaw, but if I just move a centimeter to the right, I'll probably get a better treatment out of it. And that matters in a patient who's been treating or who's been dealing with, symptoms for those 109 months. You know what I mean? Need that 1 degree or 1% difference in how they're being treated to really take the next step in their rehab journey.
Mm-hmm. Yeah, I like a lot of what you said there, and especially as it pertains to one part, which I think at the fundamental level of all of this, I hate to be, I'm going to sound skeptical in saying this, well, let me back that up. I don't want to make it sound like I'm painting everyone with a broad brush and that everything is all about money. But at the end of the day,
yes,
follow the money, right? I mean, ultimately, providers are doing certain things because that's what gets reimbursement. And I think we could dance around and be like, we're doing it to help patients. Of course we are. It's not. This is also our living and our job. And so when you're treating people, they're paying you for that service. And if the insurance reimburses it, you are automatically going to cater your treatment to what gets.
It's an inherent bias.
It's an inherent bias. And I don't mean it in a way to be critical or point fingers or say people are being unethical. It's just the nature of the system. Unfortunately, treatment follows reimbursement all the time. And It sounds like in what you're saying in physical therapy, you're able to create this practice model where you can take an hour, which is probably 50 to 55 minutes more than the pediatrician or physician would take with the patient, right? We've all been for a checkup or something, your elbow hurts or your back hurts, or you mention it to your primary care physician. Not a knock, just the reality. They don't have the time. They just want to send you to a specialist or try to get, who may also not have the time. So it sounds like one of the things you're doing, and I'm so interested in this because I find this is one of the common threads in those who think about orthodontics and as more than just mechanical tooth straightening, but think about it as whole patient care. One of the biggest differentiating factors, Vincenzo, is that those orthodontists who think about it comprehensively have a more thorough, comprehensive diagnostic process across the board.
And better outcomes. I mean, it's just
better outcomes. Yes.
One follows the other, right?
Yep.
And I don't take it the way of pointing fingers on it. And I think we're at a point in medicine where it's like, we kind of need to start pointing some fingers. You know what I mean? Like,
fair enough. Yeah.
The health of our patient is not great. I read a study from back, and I always reference this to my patients. Like, I read a study that was done back in 2012 where they surveyed, I think, over 2,000 physicians. Guess how many of them were overweight?
Of the physicians that they surveyed?
Of the physicians that they surveyed.
2,000. 1,200?
Yeah. So would I say 2,000? Yeah, over 50%.
Yeah.
So, and I can send you the study. I don't know the exact reference, but I wish I had one of those minds that's like 2012. What is that? But anyways, it's like that was back in 2012. God knows what that number is now.
Right.
My point is, if we're dealing with people who don't respect their own bodies to be healthy, how can they appreciate you charging someone X amount to spend an hour with them? They'll never understand that. That's like it's like talking to a wall, because you clearly don't value the importance of sleep, diet, and exercise. Because if you did, you wouldn't be overweight. It's that simple. And it sounds mean, but you know what? If someone's treating my mother, I'm going to talk to them a certain way, right? And I view every one of my patients that way, so I take it seriously. We can drive, and I know it's getting a little off of a tangent here, but like, the outcomes and the money that is spent investing in these patients for their problems can be driven way down if we just get to the problem faster, and that just requires more time. If you go to a traditional PT clinic, like one of those bigger chains, and I get it, not everyone has the funds to, pay one-on-one, and I totally get that. But if you go to one of those clinics, they're almost always going to recommend you see them twice a week, 3 times a week for 6 to 8 weeks. Because they don't start making money till they 8th visit. You know what I'm saying? Where someone comes into me, like this woman who saw me, Dr. Gill, today, I told her she's going to need 3 to 5 visits to get at least 60% better from where she's at. And she was shocked because all of her experience with PT in the past has not been that. And I told her point blank, I'm like, my job is to educate you, treat you, and then give you the homework. Go home and do it. If you don't want to get better, then don't come back, because you're just going to waste your time and money, And when people are a little bit more vested, they tend to take it a little bit more serious, and they're like, okay, I really got to do this because the money's coming out of my pocket, not just my insurance paying for it. So I think there's multiple benefits to doing it that way. I think as Americans in particular, we're a little adverse to, all right, I'm going to invest now to kind of reap the benefits later. It's more of like, oh my God, that's a lot of money. It's like, yeah, but you just spent, X amount on, your car or dinner, right? It's more where the priorities lie. So, I think you're spot on. And I don't think anyone should take it away at point of fingers, because that's just the reality of what we're in,
Yeah, I'm glad you said it that way, because it's true. And I try to walk that line between being overly critical and overly sensitive to what we're all experiencing and enduring as providers. And I ran a practice for almost 2 decades. I know the challenges therein. And I know a lot of people in my field that knock an early interceptive phase 1 approach is because, and I see them say it, because they can't monetize it and or there's no insurance reimbursement. And they say all the time, you're going to burn the patient's insurance reimbursement. So if they need a second phase when they're older, they won't have insurance to cover it. I hear it all the time. And I say, that is not a reason to provide, that does not provide justification for not helping this patient younger, just because you're going to burn their insurance benefit. I'm not saying you don't acknowledge that and you don't tell the parents, like, look, if you do this now, then you might, if there's additional treatment needed, it might be something out of pocket, right? You want to hide it or lie about it. That being said, if the patient can benefit from that additional time, additional proactive treatment, why not do it? So on that note, how much of what you see is on the proactive side, meaning you get patients coming in wanting to, they've got some problems. They don't have nothing wrong. Obviously, they probably wouldn't be coming to you, but they're not too bad. They're maybe noticing a little something, and you can help them so that it doesn't escalate and doesn't reach much more significant levels of impact on their activities of daily living or health or sleep or mental state. And how many are people who are really suffering? And if you could just talk a little bit about how you manage that. Like, what do you do with people that are not as far down the path of problems and they just need some guidance? And how do you get people who are really severe? What is your process to help get them out of pain?
Right. So unfortunately, I don't think it's enough of like who comes in proactively, because people generally don't tend to take this stuff into consideration until they feel something. I felt a pop in my jaw. I felt pain. I felt a headache. I felt a migraine. I've even had patients who are like, I have a 5 out of 10 headache, and they think it's normal. Like they literally baseline. So that level of education is also not as good as it should be, in my opinion. If you think a 5 out of 10 headache is normal every day. So I would say percentage-wise, maybe 10%. But what I will say is when those people become patients, when something pops up, they're far more likely to call me early on because they know I'm not going to give them the ring around, right? They know that I'm going to try and get them in and out as fast as possible and not let that flourish into something way worse. And I think a big piece of that is I've now educated them like, hey, if this happens, try X, Y, and Z. If that doesn't work, call me. Don't let this get worse, because then it's going to make my job a lot harder. And they trust it because they've seen what we've done in the past. You get what I'm saying?
Yep,
so
absolutely.
I would say almost every patient who came in for one reason or another, who ends up coming back for a new issue, comes back within 2 to 3 weeks of that issue manifesting.
Okay. Yep.
Which I think is great. We have a very good working relationship. It's almost like I become an advisor at that point.
Yep.
Now, to answer your question of like, what do I do with the severely sort of, people who are kind of on the deep end and people who aren't? My process for everyone who comes in with a head, neck, jaw issue is I always give a general body scan. So I kind of think of it as a big funnel, right? What am I seeing globally? How are they standing? Is one leg shorter than the other? Do they tend to lean to one side? Is one shoulder drop? Just to get an overall picture and not get too like sucked into that stuff. I make my notes in that arena, and then I start to kind of funnel into the neck and head. That's when I'll start to look at eyebrow level, eye level. Is the nose deviated? Is one nostril bigger than the other? Is one ear dropped? Is one ear flared in or flared out? Is the jaw deviated left? And that's just kind of looking at the symmetry of the face and the head and neck. A very common one you'll see is like, you'll see a lot of people with an elevated left shoulder and drop the right shoulder. And then you'll see their head, kind of going to the other side and turn one way or another. And then I'll just kind of ask them like, hey, what are you doing for work? What does your daily life look like? Because a lot of that could be influenced by what their job is. I can't tell you how many times you get people in finance like, yeah, I have one main computer and then one to the left. It's like, There you go.
Yep.
So that's just kind of my general scan. And then I'll look at range of motion. How well can they turn their head, look up and down, side to side. And then I'll look at the jaw. How well, how much can they open? And then how much can they open with tongue suction to give me an idea of how well the tongue is moving. And then I'll look at general coordination of the tongue in and out, tongue side to side. Can they go fat and skinny with their tongue? Can they deviate their jaw left and right? Can they dissociate their tongue from jaw movement, which is super important in terms of information. And then I'll evaluate the swallow, and I'll evaluate the hyoid in how it's moving when they swallow, which will give me a pretty good idea of like how involved is the tongue in all of this. Because it's easy to say like, if their tongue range of motion is 50% of their TMJ opening, that's one test. But it's like, what does it actually feel like? Is it because the soft tissue in the neck is actually pulling at it and it's not really a true tongue tie? Or is it actually a frenulum short? And then from there, I'll get them on their back and I'll look at, I always look at C1, C2. I'll evaluate every suture of the skull. And then from there, I'll look at all the levels of the frontal bone, the maxilla, the jaw, and then I'll go intraorally and do my eval there as well. For the people who are really far off, a lot of it is just pain reduction at first, right? Just trying to cool down tissues that are tight and tense. And a lot of it is just very, very, very gentle impulse or input from my hand. So the brain starts to get a different sense of what's coming in, right? If you're constantly clenching, your muscles only know that level of, contractility or input. If you put your finger on one of those muscles that are hot, you can sort of start to rewire that input to the brain. It's very slow, but what it happens, you start to decrease some of that pain. Then things start to open up, and then you can get into the more nuts and bolts of treatment. For the people who aren't that bad, a lot of it is it's the same process. It's just seeing where the deficit is coming from, and then I start to make a judgment call of like how much manual therapy I think they're going to need to get out of pain. Or if they're not in that much pain, it's like, here, work on these exercises. See me in 3 to 4 weeks. This way I could see how you're progressing, because they're doing fine. They're chewing fine. They can talk. They can swallow. They don't have any issues that way. And then once they come back, it's like, oh, Ben, I feel great. Okay, good. Then let's do one more session, give you a couple more, see me in 3 months. Or they're like, I'm like 10 or 20% better. It's like, okay, maybe you need a little manual therapy to push this along a little faster. Then see me in 3 to 4 months. I know that was kind of long-winded, but.
No, that was great. You explained that beautifully. And I was struck multiple times as you were going through it on how many of the things you're doing intraorally more than the average dentist or orthodontist is doing.
And until like what I'm actually looking at in the mouth, but yeah, I mean,
go ahead. If you want to go into a little more what you're doing, I think it's fascinating, especially, I have a lot of physicians and laypersons as well listen to the show, myofunctional therapists. We have a big audience of OMTs. So yeah, I think if you could explain a little more of what you're looking for, because
sure,
in dental school, we learn an intraoral cancer screening. You were talking about tongue movement, tongue function. We don't even get taught in orthodontic residencies, and we know what ankyloglossia is, but we don't necessarily know how to quantify it or when to treat it. We don't work with oral myofunctional therapists and orofacial myofunctional therapists in terms of if we do a release. I don't think a lot of people know that in the average orthodontic residency, it literally is, what is this patient's bite like? How much crowding do they have? What is causing that? Meaning, is it the upper jaw too far forward, lower too far back, et cetera, et cetera. And we don't dive into the muscular function. In fact, we deny that it even plays a role. Like, unless the patient has an anterior open bite, then we're like, oh, well, tongue thrust, right? Or a lateral open bite, oh, tongue thrust. Other than that, we're not trained to really look at that. So I'd love you to go into that in more detail.
I'll tell you short, to kind of tie this all together. It's funny you say that, the orthodontists are just kind of like looking at the bite. And some of them even say there is no relationship between the muscular amounts and like how the bite is. I
hear it all the time.
So when I first started lecturing in Westchester at certain dental clubs, I'll just say there was some resistance, right?
Yeah, I know that well. Yep.
I'm an outspoken person. I don't care, right? Like, I'm not in this
same
football. Like, I'm here to help patients. Whether we're either on this board, same train, and like you call me out for my BS, I'll call you out for your BS. Because at the end of the day, well, what are we trying to do? Get somebody better, right? It's not about me. It's about them. Yep. So every time I lecture, I always have the people in the audience stand up and close their eyes. And this is something you could try if you'd like one day. It's just, and occlude your teeth. And then, occlude more to the left and occlude more to the right. And what you'll find is your body will literally shift left foot to right foot. And then I'll have them occlude again and move their neck and head. And what they'll find is, if you occlude and look there, you'll get more towards, your molars. And if you come towards the front, you'll get more of an anterior bite. So neck position and occlusion influences the rest of the body. There's a really good paper on this called dental distress syndrome by, the name will come to me, I can't remember, but I can send you the link as well.
Yeah, please, that'd be great.
That really shows in this like review paper, he references one study where they take a group of dead rats, they x-ray the spine in normal occlusion, then they create a malocclusion and you see the spine change. Then they recorrect the malocclusion and the spine changes again. In dead rats. So it just goes to show that there's an abundance of evidence that links occlusion to the rest of the body. And I think your question was like, okay, so how do I get into that more or less with my bullshits or?
Yeah, once you start to notice that, you said you do a little deeper dive even than you had initially highlighted on the tongue function and mobility and intraoral tissues. Like I think it's fascinating for people to learn and kind of a wake-up call to my dental colleagues that we need to be a little more aware of this because that is, I think it's hard to argue that's not our wheelhouse, right? I mean, that is what we went to a lot of years of school for, yet we're ignoring, and as you said very accurately, many people are actually adamant that there is no role between the tongue, unless it's abnormal and it's a thrust or something of that nature. But unless it's something that seems to be overtly abnormal, causing a problem, we kind of ignore the fact that this is all tied in together. And I know that's a generalization. I know there are people that are listening that maybe they subspecialize in sort of pain areas or TMD areas, and they're more hyper aware of this. The average orthodontist or even dentist or pediatric dentist treating kids, I would be willing to say, and I've been involved in the profession for a long time and coached and trained a lot of people over the years, is not hyper aware of the orofacial muscular function as it relates to their patient's occlusion.
Yeah. And again, I mean, maybe I'm biased, but there is definitely a relationship. To what extent? I think we're all still, figuring that out. And where do you jump first, right? Because if you look at Anatomy Trains, the book Anatomy Trains by Tom Myers, you can trace the anterior longitudinal line all the way down to the big toe, right? So in theory, you can release the foot to have an improvement at the tongue or release the psoas to have an improvement at the tongue. What I look at is, combining what they're telling me and what their history is. So for example, a lot of times I'll get a referral from general dentists that the patient lost their crown or the crown fell off, or they fell and now their occlusion's off. And the dentist I work with, I've encouraged them like, hey, before you start shaving down teeth or balancing bites, like send them in to me. Let me see if I can treat something that can kind of recorrect what happened in that trauma or like the crown. And a lot of times what I find with them is like, they have something that, in certain cases, like they had an abdominal surgery, right? They had an appendix removed, or very common in women, cesarean section, right? Treating that soft tissue can have an effect up the chain that can release what we measure to be endoglossia. Does that make sense?
Yep.
And then, or if it doesn't, now you're just further proving like, hey, this is actually a true frenulum restriction. But before you cut, wouldn't you just treat a psoas or treat the hyoid muscles first? Because if it doesn't work, okay, we're back at the same spot. But if it does, you just save that patient a lot of time, money, and potentially, maybe some, malhealing at the end of it or an infection. Who knows, right?
And when you say release, you're saying neuromuscular release, fascial release, so to speak, not surgical release. You're drawing a distinction between those two. Okay. Yep.
Like what I would do in office. So how I explain to my patients is, we all know fascia is like all encompassing throughout the body. And how I usually explain to my patients, I say like, if you've eaten a sausage, the sausage has a casing around it. The meat inside can move and glide. Once the casing is so restrictive that the muscles can't move and glide, you need to have some sort of intervention, whether it be, manual therapy or some sort of like red light therapy or compression therapy. The list goes on and on and on. Obviously, I use my hands. That's what I prefer because I can feel things. If you can get the muscle to slide and glide underneath the casing a bit better, now you may find that things are moving the way they should be rather than just taking one objective measure and precision. So commonly you'll find hyoid restrictions. one hyoid muscle or tongue muscle is pulling the hyoid to the left or to the right. So releasing that and then repositioning the hyoid bone and then retraining the tongue and retraining the neck afterwards so they maintain that position. Intraorally treating the pterygoids, which could be pulling on the mylohyoid or the genioglossus in one direction or another. How does that pertain to an orthodontist? Well, if they're constantly chewing on their left side, right, because that's where they're hitting and that's where they feel most comfortable chewing, then it's going to present the pattern intraorally and create some certain tensions that may be allowing them to keep that pattern and also creating certain pains or dysfunctions. You with me?
Absolutely.
And that's intraorally. And then extraorally, in Western medicine, in school we're taught the skull fuses at a certain age and the sutures don't move. If you talk to a lot of myofunctional therapists, craniosacral therapists, we don't believe that. I personally don't believe that. I've seen too much good to believe that. And there's different work you can do there. You could use a lot of gentle touch approach, which would be more along the craniosacral approach or lines of treatment, which you may be great for someone who's so inflamed and like you can't even put your hands on them. But could also be great for someone who has more of a deeper restriction in their cranium or their skull bones, like the sphenoid, the ethmoid, so on and so forth. That can really open things up or reduce restrictions that have come from traumas or even birth traumas or just habitual patterns. And then, a common one I see is you always see a temporal bone rotated one way or another. And then the mastoid's kind of bumping into the mandible, which can create some dysfunction at the TMJ. So I guess what I'm trying to say in all these scenarios, you kind of have to ask the next question. It's like, okay, the tongue's tight, but why? What could be all the possible reasons why the tongue or the jaw might be functioning this way? And start using clinical reasoning and experience to say, it might be this. And as you're treating down those lines, if they don't work, that's when it's like, you know what, maybe it is the fact that their occlusion's a little off. Let me call someone like Mike and say, hey, I gave this woman everything I got. She's not getting better. Can you just take a look at her occlusion? Because I have an education about occlusive things, but I'm not an expert. You know what I mean? I'm just a PT trying to learn a little bit more about dentistry so I can better help my patients. But what you're basically hinting at and what we've been talking about is like communication, right? Like acknowledging that there's a relationship, understanding we both have a role to play in this, but when we come in is kind of, what we're figuring out on this podcast or what we would figure out over a patient case or something like that.
Hey everybody, I want to take a moment to tell you about this year's Airway Palooza, which is happening October 17th and 18th in beautiful Fort Lauderdale, Florida. This year's theme is From Downstream to Upstream, the life-saving shift, and will focus on something I'm a big proponent of, which is solving root causes to promote airway health as opposed to simply treating symptoms. That's why I'm honored to be co-chairing this event, and we have an amazing lineup of speakers, including general dentists, orthodontists, pediatric dentists, oral and maxillofacial surgeons, ENTs, board-certified sleep physicians, myofunctional therapists, lactation consultants, and craniofacial specialists, all in one conference setting. There will also be social events both evenings, so you'll have the opportunity to meet and brainstorm with colleagues beachside in Fort Lauderdale. Airway Palooza is the only airway-focused event to be nominated for Best Dental Conference of the Year. Plus, as a special gift for listeners of the Doc Podcast, you can receive a $500 discount off your registration fee by entering the code DOCPalooza at checkout. That's DOCPALOOZA to get $500 off your registration fee. I'll put a code along with a link to the conference registration page in the show notes for today's show. So don't miss out on this opportunity to participate in this amazing collaborative event. Get your tickets to Airway Palooza 2025 now before they sell out. And now, back to today's episode. Yeah, and we understand that there's an impact of musculature on the occlusion. We tend to only think about it, though, in patients who are symptomatic. Meaning, if we get a patient that comes in and they have significant TMD, whether it's unilateral, bilateral, whether it's clicking, let's say it's an internal derangement, something going on, we know one of the main ways you try to quiet that is a deprogramming splint, right? Well, why are you doing that? Because you're trying to, in a different way than you are, with more, that's more of an indirect approach, where yours is more of a direct approach, where you're directly releasing. We're trying to indirectly let these muscles calm down so that they can't get into that position that was causing the pathology. So again, we understand that. What I don't think we think enough about is proactively, maybe that patient is not so symptomatic that they can't open or close or chew, right? Mm-hmm. But maybe they just have some underlying asymmetries or underlying tongue mobility issues. And we tend to gloss over that, I think, unless it's a major problem staring us right in the face. Yet again, we know that the head and neck musculature plays an intimate role in patients with TMD. So it's interesting. I just think it's interesting to kind of call that out and highlight that and say, I think of my own patients, and again, being reflective and acknowledging my failures. How many times I probably had a patient that had some of those underlying issues, a little click, a little this, a little that, and I'm just all focused on, well, I'll disocclude them, I'll get the bite, reprogram, rebuild it, not thinking, hey, look, maybe I should have PT involved or myofunctional therapy involved to help try to figure out some of these compensations they're building in, which are contributing to this. And I would often see patients that when I would treat them, they would get a lot better. I would be able to deprogram them. I would get the bite to fit better. But some of those patients down the road in retention would start to have symptoms creep back up and in. And I think how many of those patients really needed the level of therapy that you are prescribing and providing for your patients that I just didn't know about. I just didn't know that it was an adjunct that I could utilize.
Yeah, no, I think that's a great point, and I think it goes both ways. Like, PTs need to do a better job educating themselves of how we can better help, dentistry and throughout all facets, right? Endodontists, prosthodontists, general dentistry, orthodontists, and even the TMJ guys. How can we help you guys identify those things, because you're the first point of contact. Mm-hmm. It's something I encourage dentists to do that I network with, is just come in and get treated, right? You could ask me all day long what I do, how do I eval, and it's great, right? It's a good educational tool, but until you feel what someone can do and help change something you feel in your body with their hands, it's almost, I don't want to say meaningless, because it's not, but it is in a sense, because you don't fully understand it until you feel it, right? And a lot of the dentists that refer to me end up either becoming a patient, or because I treat them once, as a way of showing them what it is that any PT can do if they train themselves to. But I totally agree with you. I think, for example, if I had to look at where I've had shortcomings, it's identifying big pathologies or like red flag pathologies in patients, because we don't have access to imaging, right? Or someone who's got some resorption may not present a certain way when they come in. It may present like just a typical, either a disc derangement or a lack of opening. And I've missed that in the past until they had imaging. But it's like, how many patients you can't refer everyone for imaging. It just dilutes it, or it makes treatment so much more complicated for them. But I think on our end, we could do a better job educating ourselves and learning of, like, okay, they open up 10 millimeters, or they have significant pain, or there was a the mechanism of injury was just so abrupt, maybe take a step back and get some imaging before intervening. But I think on both ends, right, it just requires education and a willingness to learn what else is out there that can give our patients the best chance of getting better.
Yeah, it's such a great point, because we rely on the imaging. I had CBCT going back to 2014. I would look, you get beautiful images of the jaw joints, the TMJ apparatus, and I'd be like, anatomically, this patient's fine, and so I'm hyper focused on that. Obviously, if I saw something that wasn't normal, I knew how to deal with that and handle that. But those are the ones I was missing, that it probably was more neuromuscular in a lot of ways. And I'm hyper focused on the anatomy, and vice versa, or the converse of that would be in your position. You're hyper focused on the neuromuscular side, but you don't have the advantage of having that imaging or the training to look at that image to that extent. So yeah, it's just another example. And back to Peter Attia, Medicine 3.0, we have to become less siloed. We have to work together. But an interesting part of that is that gets really overwhelming and expensive for the patient. And it's like, it's so great to say because it needs to be said. And it's not being woo-woo or idealistic, like, oh, you need all these providers. But in dealing with and treating patients over the years, there's only so much bandwidth people have for going to different doctor's appointments and different imaging. So it's hard. And obviously it's more than you and I can sit here and solve in an episode of the podcast. But I just want to acknowledge that for patients listening and laypersons listening who aren't on the provider end of this. We get it. It's not easy, or parents of patients. I hear that all the time too. And we'll talk about the Airway side a bit more in a second, but the parents just they get burned out. They get tired. It's really hard to go to all these different providers, and it's expensive. So it's a challenge.
It is. See it all the time. And there's so many people I'd like to refer my patients to, but oftentimes it's like, oh, another person, you know what I mean? It's a challenge, and it's a challenge that comes up constantly in conversation with other practitioners. There's two great myofunctional therapists that you may know, Nicole and Heddle. They're like 5 minutes down the road from me. And this is a conversation that comes up with us quite often, where it's like, how many people can go to the orthodontist, then the PT, then the myofunctional? It's like your life becomes treatment, and that's not feasible either. But I think these are great tools, right? Because now people can sort of hear and say, okay, maybe I should start here. Let me try this for X amount of time. And then that person can help guide me to the next step if needed.
Yeah. And I think our educational system in every aspect, I mean, now you guys are at the point you're getting a PhD, you're in school for a lot of years. We're in school for a lot of years. It's unacceptable that our education, you said you had maybe 2 hours or whatever on.
There's no reason I need to be in school that long.
Right.
I have my own ideas on how they can reform it, but the bottom line is I should have been out of school a lot sooner and been shadowing practitioners way faster, to save money and time on our end.
Yeah, and we need to, there's so many antiquated things that we're learning because it's just always the way we've done it in dentistry. And because there's only so much time and you can only fit so much in, they're not doing a lot of the more modern progressive education because it's like, well, this is the way we've done it. And in educational institutions, especially in dentistry, a lot of the faculty are older. They've been institutionalized. A lot of them aren't even licensed to practice outside of the school. They are there because they have never had or been able to have a license in the U.S. For private practice or have a license in that state to practice. They have their degree, they have their DDS or DMD, but they've never done it outside of that. And this isn't a knock. This is just the truth. I've been involved in academia since if you count my 11 years after high school, plus the 20 I've been out after that, for over 30 years, I've been involved in academia, either directly as a student or indirectly as a teacher. And it hasn't changed much. It hasn't changed much. It's still very much teaching the same concepts, and I think we need. And medicine, I know, is the same way from having physicians on to talk about the same thing. So, on that, how did you then? So you're shadowing Dr. Gelb, and another gentleman said Brad was in Greenwich. You're shadowing them. You're starting to see things differently. Kudos to you, by the way, for having an open mind. That's a big thing I find is a lot of people just maybe don't have that open mind, or they think, well, I've learned it this way. This is the way, I'm going to do it the way I learned it because that has to be right. So you kept an open mind. You were a critical thinker. You were evaluating what you were seeing and using your knowledge and expertise to make decisions. You're seeing them do things. And at what point, I get the TMD side because again, it's in your wheelhouse and you're learning about muscular function and joints. It's what you do as a PT. How does that jump over into the Airway arena? At what point are you realizing, like, wait, there's a crossover here that I could be a part of?
Right. The thing that jumped out to me the most is read any article about OSA, right? What's the first thing that comes out? If you're overweight or obese, that's the first thing that needs to be addressed, right? And I already know, and because I've heard this counter argument, they're like, well, if they can't breathe, they can't exercise. It's like, yes, but what are you telling me? They can't go for a walk? Like, they don't have to go be an Olympian, but they should be moving. And every dentist or any practitioner that, like sleep medicine doc that was dealing with this, like that conversation wasn't even being had. And the God's honest truth that I think the reason we're having that conversation is because they're scared they're going to lose a patient. It's like, that's ridiculous. Like, you're not addressing the elephant in the room because you're afraid you're going to hurt their feelings. I'm not saying you have to be disrespectful to the person, but it's medical information.
Right.
One of the main, and this is well documented in literature, one of the main reasons you are sleeping poorly is because you are severely overweight. And I found that the other reason they didn't want to tell these patients because they didn't know how to manage that, right? Like, what is, okay, fine. You identified they're overweight, they're obese. That's definitely a contributing factor. Maybe it's not the whole picture, but it is a big contributing factor, right? Okay, what do you do with that? How do you educate them on nutrition? How do you educate them on exercise? What are the parameters, right? Like, go for a walk. Or people say, like, go meditate. It's like, that's such a vague, recommendation. Right. It's like, how do you expect anybody to follow that, let alone be successful 4, 5, 6 months down the road?
Right.
And I felt like my strength and conditioning background really set me up nicely for that, because it's like, oh, boom, like, you're going to do this for 3 weeks, you're going to do that until 6 weeks. We're going to recheck in at 6 weeks. We're going to change the plan because at this point you should have lost this much weight if you follow it and you eat this, blah, 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 blah. Some of that was self-study. Some of that was given to me in school. Some of that was just me working, right? Like learning other practitioners and picking up things from them. And I saw that even in the PT space, no one was addressing the elephant in the room.
That's interesting. Even in the PT space, huh?
Even in the PT space, like it's like people are petrified that they're going to offend somebody.
Yeah.
I'll be honest with you, she's still a patient of mine. She came in for sleep issues. And I said, you're 40 pounds overweight. She called me like 3 hours later and was like, I can't believe you told me that. I said, listen, if you're upset, I apologize. But I'm not going to apologize for giving you medical information. If you're not willing to take that in, go find someone who's going to pamper you, because I'm not going to do it. You know what I mean? Like, we're not going to get anywhere if you're not willing to address the root of the issue.
Right. You're not doing them any favors. You're not doing anyone any favors at that point.
No, you're not. And again, I hope this isn't coming off as like rude and crude. I'm not trying to portray it that way. But our job is to be honest with our patients for their best interest. Their job is to receive the info and decide what they want to do with it. If you look me in the face and say, Ben, I'm not losing weight, but I still want you to help me. Okay, we had the conversation. We understand the objectives. We understand the goals, and we know what you are going to do and what you're not going to do. But to not even go about having a conversation out of it because you're not sure how they're going to respond is malpractice, in my opinion.
Yeah, fair enough.
So that's kind of, I saw that start happening in the PT realm, and I'm like, wow, I have a knowledge base in exercise that can really help these people out and help them get from a place where they're so crippled, right? Because the other side of it is, if you go to some personal trainers or strength coaches, like, day one, they're having you do 50 squats. It's like, take it easy.
Yeah, I see it at the gym all the time. I'm like, oh my God, which is like entry-level trainers. It literally, I just saw it yesterday. I was like, oh my gosh, like you just...
you see the person dying. It's like, take it easy. They're not ready.
And they rarely ever are coming back, at least not to that person. It's a couple sessions and they're done because it's just pushing them past what they can do.
It's too much. And they're not setting the right expectation. It's like, for example, the woman who just came in, I was like, she's like, when am I going to feel like myself again? 6 months to a year. That's how long it's going to take to get your body back to where you want it to be.
Yep.
Like, it's not going to happen overnight. I would love, believe me, if I could sell that in a pill,
right?
Believe me, I'd be on a boat right now and I'm okay. I wouldn't be having this conversation. But my point is, that's part of it, right? Like, that person comes in, they're 50 pounds overweight. If you go at just half a pound a week, you're looking at over a year. You know what I'm saying? To lose that much weight, which is going to impact your OSA. Long way of saying that's how I kind of thought I could really inject myself into helping those people. And my personality is just to be honest, because again, it's all about getting them better. They got to want it. If they don't, then we move on to the next one, because they're just going to be looking for that quick fix, which is never going to help them anyway. Secondarily, I thought my manual skills could really help with things like, for example, if they do have a tongue tie or a fat tongue or limited space in their maxilla. So we can actually do some manual spreading of the maxilla at the suture to help create a little space for the tongue and releasing some of the soft tissue, which would help with swallowing and not allowing the tongue to drop back if they're, laying on their back when they're sleeping. And then there's intranasal work we can do as well.
Interesting.
Soft tissue work through the maxilla and the nose. And then there's a lot of craniosacral techniques that really help with the sphenoid and the frontal bone to clear some of the nasal passageways so they can breathe through their nose better. Therefore, it'll help some of the OSA symptoms.
There's almost some crossover with chiropractic, interestingly, right? I mean, in terms of, yeah.
I do. So grade 5 manipulations is the POP. I'm trained in them. I know how to use them. I got to be honest, I don't use them that often. It's just not my style. I'm not saying wrong. Just not how I choose to treat. But, I've referred to chiros in the past where I think they have, they're manipulating more than I am. It's like, hey, I can't get this joint to move. Just crack it for me and send them back, because I think if they get that, I can get more done with them. And then lastly, like posturing plays a big role. Like we all know, you're rounding forward and your airway is getting fluid, and then you open to breathe. So get people a little bit straighter and a little stronger through their backs and to help.
That posterior chain is big, isn't it?
100%. I mean, I hate to sound like this is all strength training, but a lot of it is. Like people don't realize it's not just being overweight. We're sarcopenic. Like our society is so weak. Like baseline of our physicality is so bad, and there's not a lot of talk. I think it's starting to come out more now. There's not a lot of talk of like how your physicality and physical fitness can really impact your breathing, your pain sensations, your overall feeling of, how do I feel day to day? Do I feel good or do I feel bad? Like they feel bad because they've never felt good.
You get completely used to it. You completely acclimate to your pain. You completely do. And you just, like you said, someone whose headaches are 5 out of 10, they think 5 is baseline.
No.
Right? They don't know that a 1 or a 0 even exist.
That's crazy.
Yeah.
And it's a little disheartening, but it's nice that people like you and I exist. And there's, many people like Penny like that I met. And it's like, oh, great. We're all on the same wavelength here. And I do think the tide's changing a little bit, from politics down to like things like podcasts like this, where people are like, holy crap, like I should wake up and not be craving a cup of coffee. I mean, I'm guilty. I crave my cup of coffee. But my point is like that the acknowledgement of like, I shouldn't have to crave it tells me something else is going on,
Right. Or craving it for the enjoyment or the flavor versus the I cannot wake up unless I have a drug of caffeine in my body. I mean, I love a cup of coffee in the morning, but if I miss it, it's not like it ruins my day, more than just the enjoyment.
Me, Mike.
What's that?
I say you're a better man than me. My problem is personally, I don't get enough hours of sleep.
That was me for a long time, though. I've been able to improve that recently, but I went through many years where I was not doing well. And I'm talking like 5.5. I'm embarrassed to say it, but again, on the note of admitting your failures, 5-6 hours of sleep was a real good night for me during my busiest years in my practice. And my kids were young, and I owned a bunch of other businesses, and I'm not saying that at all in a proud way. I'm saying it a bit embarrassed, because as a healthcare provider and fitness enthusiast, I should know better. That being said, I did what I did, and I noticed a dramatic difference once I even got up to like 7 hours, 7.5 hours. I mean, I felt like a different human. That was during COVID was when it happened. And I was like, oh my God, this is what I feel like rested. It's a whole different world, and it's a whole nother topic, but the impact of sleep. So, I guess actually on that, so how much do you get into it? I mean, do you get into, are you developing diet plans for these people? Because again, just thinking on the extent to which you need to develop a diagnosis and then treatment plan, right? If you are getting into diet and exercise and sleep and hydration, I mean, are you getting into all of that? And if so, how do you have the time and resources to really implement these types of comprehensive plans?
Yeah, it depends. It really depends on the interest of the patient, right?
Okay.
Like so in my intake form, there's a question on there. There's a couple questions like, how interested are you in this? And I take note of that, right? Because like, if they're coming in for a certain issue and they're like, I have a lot of people like, they always check, no, I'm not interested in learning about my diet and nutrition. I'm not going to start there because it's already an uphill battle. Like that patient, I need to gain a relationship, I need to gain some trust. I need to show them that I can help them beyond that first.
Yep.
There are also patients who come in who are like, they just start talking about it. And the whole eval is like diet, sleep. And their main problem is they're like, I have nowhere to start. And part of it is we're an information overload.
Yes.
Right? So like, I listened to the Andrew Huberman, and they're like, I'm not sleeping 8 hours. I'm not getting sunlight. It's like, relax. Like, it's okay. Like, and I kind of humanize with them. Like, listen, I get 6 hours. That's where right now at my life, that's where I'm at. I'm getting 6 hours. Mm-hmm. I need that cup of coffee. I'm not going to hide it. I'm not perfect. Right. And I kind of get on their level. It's like, I get it. You know what I'm saying? Like, you're working 10 hours. You're commuting you got 2 kids. This one's not sleeping. That one's sick. you got a relationship to keep up with your wife and your other family members and friends. It's a lot.
Yep.
And they kind of come in and unload it on me. And then I'm like, okay, take a breath. You don't have to, kill every bird with every stone right now. Mm-hmm. I asked them, where do they think they would succeed the most? Do you think you're going to succeed by getting an extra hour sleep? Do you think you're going to succeed by drinking an extra bottle of water? Do you think you're going to succeed by eating an extra meal or trying to get your protein up? Whatever their response is where I go. Because all I'm trying to do with that patient at that point is get it going, right? Like gain some steps in the right successful motion. Like a patient comes in, they're like, I could definitely get an extra hour sleep. That's easy. Like, I know, I just got to put my phone down. Okay, you really think you're going to be successful at that? Yes, man. No. Like, you really think you're going to be successful, right? Because like, that's not bullshit here, right? Like, if you're going to be successful, that's where we'll start, and you will have results from it. But I want you to just gain some momentum. Yes, okay. So tonight, bed at 9:00. Or some other people are like, I'm 30 grams away from hitting the amount of protein I need to hit. Okay, start there. That just means you need another half a chicken breast or chicken breast, whatever it is, right? Mm-hmm. Or some people are like, I really enjoy walking my dog. Perfect. Why don't you start your day with walking your dog instead of waiting to the afternoon where you may not do it, right? Like, then I can get up an extra half hour. So it really depends on where they're at and what they're willing to get into. I'll ask them point blank, like, hey, you care if we spend our time? Like I always say, like, listen, I've done my eval. I have an idea of what's going on. Do you mind if I get into this with you a little bit? And they're like, yeah, take all the time you need. Or some people are like, no, look, I'm in a lot of pain. Get me out of pain. And, with time now, I just read the room. Like, okay, they're in a lot of pain. Like, get on the table. Let's get you out of pain. This conversation can wait. Because if you're in that much pain, none of this info is in anyway.
Right. They're not going to process it or have the tolerance for it anyway. Right.
And sometimes I refer out. Like I have, there's a great strength and conditioning coach down the road from me. She does some nutrition work. She does excellent programs. She actually programs for me. I don't even bother doing my own programming. And her name's Danny. The gym's called Strength Beyond Barbell. But like if I have someone who's like really into it and I've gotten them to a certain point, I'm like, listen, you don't need me anymore. You're overpaying for PT. Go to the strength and conditioning coach. Let her write you a program. Do a few sessions, and then you're kind of on your own. And use that as like an accountability check-in thing. So it's kind of like a smooth transition to that sometimes too.
Yeah, that's great. And I appreciate you explaining that. And it's clear that your personal skills and your ability to read the room, using your words, are very important. You're very astute in that arena, and your ability to see your patients for more than just the problem they come in with is something I want to commend you for, because a lot of us, we just, if someone comes in and they're like, my back hurts, it's like, you want to treat the problem, right? And that's one of the things I say to a lot of my orthodontic colleagues is patients come in for quote unquote crooked teeth, right? Or an overbite. Look deeper. Look deeper. There's more going on there, and
involve them in that.
And involve them, right? Like I want to ask you more about the Airway side here, but in a second. But on the orthodontic side with the Airway, when I coach and train docs, one of the things I have to do is I actually have to talk to them about how to start to implement this gradually, just like you said with the diet changes or the phone changes or the sleep changes. Right. Because if you just walk in the room, Barry Raphael was on recently, who was at the PANI meeting as well. You may know him from, so he was on, he talked about how when he first learned this, he got all this knowledge, he would walk in the room and the patient comes, a 7-year-old kid or whatever walks in because they've got some teeth crumbing and crooked. He's like, your child can't breathe. They're not going to do well in school. He was kind of, and the parents are like, okay, time out, we're out of here. So It's important to read that room. And for the orthodontist, dentist, get a history, look deep. Don't just look at the yes, no, standard medical history, look at the main systems or everything's fine, the patient's fine. There's more to it than that a lot of times. And it's our job as diagnosticians. So again, I want to highlight that your skills and your effort and your energy as a diagnostician is so important in what you do. And I feel like a lot of times, and I often say, it's my belief, there is evidence on this as well, that it's what we started talking about at the beginning, because you're not rewarded or reimbursed as much in our business model, at least, for your time in diagnosis, right? I mean, in the ADA codes, you get reimbursement for treatment. So we overlook the diagnostics to get right to the treatment and the billable procedures. And as you said earlier, when you spend more time on diagnostics, your treatment is better and easier, and the patients have a smoother process, as well as you get them engaged, which you alluded to, that you need them on board in this journey, whatever it is. So on that, with the airway side, how do you, because most people probably aren't, when they have sleep apnea or an airway problem, they're probably not calling, and maybe I'm wrong, let me know, calling the physical therapist as their first line of defense. How are they presenting to you, and what are you doing with them? Hey, everybody. We all know that we don't learn much about interceptive orthodontic treatment, especially as it pertains to airway. That's why I created a comprehensive CE course that you can access through the doc website. This 26-hour course will transform how you think about and approach interceptive treatment and teach you how to implement airway-focused orthodontic treatment into your practice. Just go to theorthocoach.com and click on the courses dropdown. I'll also put a link to it in the show notes for today's episode. If you're looking for ways to improve the health and truly change the lives of your young patients, then this course is for you. And now back to today's episode.
Most of the time, first of all, no one's calling me for OSA. If people find me, it's usually because they're having pain, right? Pain is like the way they get into the clinic. And then the conversation evolves to, I ask all my patients how they sleep. Back pain, it doesn't matter, because I'm just a firm believer in the information is so abundant that like that is a really big cornerstone to getting someone to feeling better. If they're not interested, then that conversation can be much shorter, like I said. But so they're coming in with jaw pain or some sort of headache or migraine, and then the conversation evolves to, okay, well, these are all things that you need to heal from. So sleep is cornerstone. Okay. How many hours of sleep are you getting? Do you sleep through the night? If you wake up, why are you waking up? Is it the dog? Is it the kids? Is your mind racing? Are you dreaming? What time do you go to bed? What time do you wake up? Have you always had that routine? Are you a night person or are you a morning person? Mm-hmm. What are you doing 2 hours before bed? What are you doing as soon as you wake up in the morning? Those all give me a clue into like their sleep hygiene, so to speak. Mm-hmm. If I suspect they have breathing issues, sometimes I will refer them out to like a sleep medicine doc or someone like Dr. Gallup to give them a watch pad so they can actually start to get some numbers and say like, okay. You actually have OSA. If I think, based off what they're telling me, right? Because I'm not using, I'll be honest, I don't use any like standard measures. I don't think they work for the practice that I have. And I feel like I have a good enough pulse on like, if they're coming from them anyway, like if they're coming from someone like Dr. Gallup anyway, he's already had this conversation. This is overkill. Plus he's probably recommending them they do a sleep test. Mm-hmm. So by the time they get to me, that conversation's almost been had. Plus they're getting the test that they need done. When they get to me, it's like, are we just addressing the pain? Mm-hmm. If they're on some sort of appliance therapy or they're trying to lose weight to help their OSA, my job at that point is just to be a support system, right? Like, what can I release from a soft tissue and joint perspective that'll allow their breathing to be better? Mm-hmm. What can I educate them on in terms of positioning throughout the day, plus when they're sleeping to improve their sleep? What other things can we chat about that might make their sleep better? Can we talk about like using a boom boom stick? Can we talk about using, forgot the nasal expanders and what they're called, but just giving them like multiple of those to try and see how they work. Do we have the conversation of potentially even mouth taping, or maybe mouth taping during the day so they just get the feeling of breathing through the nose and then kind of work their way up, like they take a nap with the mouth tape, see how it goes instead of just jumping right into like taping your mouth shut if you've never done that your whole life. And that sort of becomes my role in terms of managing those patients. And then, when I get someone who's really got OSA, like, they have, they're waking up 20 times a night or something like that, have 20 sleep disturbances, then it's like a team effort. It's like, hey, do we have the right appliance? Is it fitting right? Is the appliance maybe causing some of their pain? How does their neck and head feel when they're in the appliance, to make sure that there's a nice snug fit between what they're prescribing and what's happening to their head, neck, and the rest of their body, because the appliance will affect that stuff. Sure. So it's nice to have me there to just double check the work. And oftentimes when I, would chat with Dr. Gallup, I would be feeling as he would be adjusting the appliance to make sure the patient walked away with the best fitting appliance. If anything changed, make changes along the way.
Okay, interesting. Well, thank you for explaining that. It's really cool to hear that. Until we started speaking, and I'm learning a lot from you on this, I was not aware of the role that physical therapy could play directly in that, but it makes complete and total sense. And as you said, just the simple fact that we know that mandibular advancement devices, they posture you to a different position, and you can develop then other neuromuscular compensations to deal with that. So, I mean, the physiology and the biology of it makes complete sense. Want to touch on some preventative things that we can do, all of us, and then we'll kind of get into more profession specific to finish up. But like, what are some of the things that we can all do to have a stronger posterior chain, have stronger core musculature and core stability, neck posture with our phones and looking down all the time or being on computers? I mean, what are some of just maybe give us 3 to 5 things that you could just say out there, and you're not diagnosing or treating anybody. I want to make that clear. Just generally speaking, in your experience, that if people just did these things, whether it's breathing exercises or postural exercises or whatever, or walking, whatever it is, that could really help them live a healthier and more pain-free life.
So I'm going to put a spin on this because I find that the problem clinicians and even patients find is like, when am I doing this and how can I implement it and how much of it? So I like to give concepts to my patients and sort of ground like bigger rules, and then they can make it fit however it fits in their life. So for example, treating an oral surgeon right now, obviously he's stuck like this most of the day.
Yeah.
Okay. So then our conversation evolved into, what are you doing when a patient's late? What are you doing on your lunch break? What are you doing when you're taking notes? What are you doing when you're chatting with another colleague in the office or the front office about, whatever it may be? Those are perfect times to use 1 or 2 minute instances to then add up to 10, 20, or maybe even 30 minutes a day of changing positions. For example, you're doing your notes, you're on your computer, deep squat, sit in a lunge, sit cross-legged. Okay, sit Indian style, whatever. You're talking to a colleague, get on the corner of the wall, roll your traps out, roll your pecs out, right? Stretch, work, right? You're having all these conversations. I could have this conversation with you in a deep squat right now, just to open up my hips and lower back. You get what I'm saying? So that's it's a good question. I think the better answer would be, that's how you fit all these things in. And then the other piece, which I always harp on with my patients, is most people at the end of the day, whether they're going to bed at 10 or 11 o'clock, there's usually an hour of downtime, right? Like kids are asleep, dishes are washed, laundry's done. It's just like, and they just kind of crash on the couch. That's a perfect opportunity to take any exercise you've learned and just reinforce it at the end of the day. And it doesn't have to be, thought-provoking. If you've been given a foam roll exercise or one breathing drill, fit it in there. Because there's a million exercises I could tell you that are all great. It's more about the practical implementation of it. The best advice I can give my patients and therapists, clinicians, whatever, find those pockets of your day where it's dead time, and now insert that. And you don't need 5 minutes of it. 1 minute is enough, because if you do 1 minute 5 times, you just gain 5 minutes.
Yep.
You get what I'm saying?
Exercise snacks. Is it I was listening to someone at one point. They called them exercise. Again, maybe he was on Huberman. Someone in the fitness arena, and they were talking about exercise snacks, like just little things throughout the day. And we all know if you sit in the same position for a long time, like think about a long car ride. You get out, you just feel tight. Your back feels tight. Your knees feel tight. It's inevitable. Yet we will sit at a computer, and I'm guilty of this too. Or dentists or hygienists would, especially in the dental profession, when I was doing general dentistry, I could sit at the chair for 2 hours, 3 hours, and you don't move. You literally, micro movements that you're going through, and we have an amazing ability to do that. We don't realize the impact that that's having on our bodies. So it's funny you said that, because Kevin McLaughlin, who I had on, it's the only other PT I've ever had on. He was my PT when I was up in New York and practicing, and he helped me through some things, elbow and wrist, that again, just strain from little micro traumas of doing what we do day in and day out. And a lot of that, he would be like, if you're sitting at a stoplight on the way into work, like start stretching your wrists out and start doing some neck exercises in the car. And exactly like you said, when you're writing a note in the charts, move your positioning, shift, don't sit all the way back in the chair. It's a great point, because we don't think about it that way, but all of those little things we can do, they do add up throughout a day. And he would say, he's like, in a long procedure, like you need to take a second and just put your arms down and just, relax. If you're going to be doing this for hours, take a moment and just put your arms straight and stretch your wrists. And it sounds silly, but it really does make a difference.
It does. And I think he's 100% right. I think the other point that I would make is, listen, every job has its physical component that is not conducive to our health. It just is what it is, right?
Yep.
So what you do out of work becomes so much more important, right? Like you are literally training not only for your own physical fitness, but so you can continue to do your profession, your job, the thing that makes you money, makes you happy, whatever it is, fill in the blank. If you work for 8 hours, it's very hard to undo a lot of the quote unquote damage that comes along with it in an hour at the gym. But not doing any of that just accelerates the problems. And that's where I'd say finding someone who's local, finding someone who's out of network, who's going to spend an hour, who's going to do a deep dive into your history and really do a thorough eval and say, I know what's wrong. Here's what you need to do. Start here is worth its money 10 times over. Because the reality of the situation is, listen, I have numerous credentials. I still have someone programmed for me, right? Why? Because that girl does it every day, and that is her job. She's so much better at it than I am that I trust her to give it to me because that's what's going to make me be more successful. And oftentimes as medical professionals, we think we may know it all, right? Or like, okay, I know how to research this. Or no, you don't. It's just flat out, you don't. Having someone to guide you through it, it's well worth your time and money because they're going to thin slice it real fast and give you a plan that's probably going to be way more conducive than you trying to YouTube it. YouTube the dresser. You get what I'm saying? Like,
right.
You know what I mean? Like,
right.
This is different, especially people who are physical with our, your profession. Oral surgeons are big and endodontists are big because they're there all day long. Invest the time. I'm treating an endodontist right now, and she's like, I can't believe we met at a lecture. She's like, I can't believe I didn't do this sooner. She's like, I literally treated for 30 years with neck and shoulder pain. I didn't do anything crazy. It's literally not, it wasn't anything mind-boggling. It was just giving her some simple advice. And that paid dividends for her because she never did that in the past. You know what I'm saying? So, but if I had to give you one exercise, if you're typing on your laptop, go on your belly. This way you get some extension.
Okay, interesting. Yeah. And the other thing that strikes me, and it's been a constant theme throughout our conversation, is treating the etiology, not the symptom. Yeah. And I think so often in medicine, in healthcare, again, like I said, it's been the constant theme. We started actually talking about this, ironically, in a different vein. It's treating the symptoms, right? It's not taking enough time in the diagnostics. And then because you don't take time in the diagnostics, you treat the back when they have back pain. You treat the shoulder when they have shoulder pain. You treat the teeth when they have a malocclusion. And we don't take the time to stop and think, what else is going on here with this patient? Because we become myopic and we are siloed. And it is a lot to think about. And we don't often learn about a lot of this in our own training and schooling. And then we get out and we're not doing it. And then we're all of a sudden going to change everything and the way we do it. And you clearly were able to have some great mentors early on and again, an open mind to be able to see this differently. What is your advice to finish up to people who hear this and think, I didn't learn any of that? Vincenzo, Mike, yeah, great. That's nice for you guys to say this stuff. But at the end of the day, that's not the way I'm going to practice. There's no evidence to that. And I'm just going to stick to my treatments that I provide. What would be your advice to those people?
If evidence made medicine progress, we'd be nowhere, because at some point someone had to try something that hadn't been tested before to see if it would work, right? And I'm not saying go out and do the hardest treatment possible and see what the response is, but get with people who maybe have and have been more pioneers and have tried things that maybe were against the grain at first, and then eventually they became more of the mainstream. I think finding people who have experience in the arena is huge, because there's nothing that takes away experience, because experience is the best educator, in my opinion. The mistakes teach you, the successes teach you, the repetition teaches you. Reading and educating and listening to podcasts is obviously great, right? Like, no one's sitting here saying, don't read a book, but we're saying get in front of the person who's done this for 30 years. maybe they're outdated, but you can still learn a lot from them. And I think the other piece is, I'm sure you would agree with this, is like, the more I treat, the more I realize, holy shit, I don't know anything. It's like
completely. It's but you have to be open to that. It takes you to a little bit of an uncomfortable place sometimes. Yeah.
Oh, 100%. I mean, I'm sure you've been in a situation like you size up the patient and you think that the treatment's going to go great, and then whatever, 2 weeks, 2 months, 2 years, whatever it is, into the gym, you're like, oh my God, I completely underestimated this.
Yeah.
Or overestimated on that count. And you kind of got to eat some humble pie sometimes and drive home and reflect and say, okay, this is what went well. This is what's not. Something that's helped me, especially for younger clinicians. And I made this a point for when I started working. And I can't remember if someone gave me this advice or I just thought about it. I really don't remember. But when I drive home, if I'm not on a phone call or, distracted with something else, I kind of go through each patient and I say, what went well? What went wrong? And if nothing really went wrong, it's like, okay, well, what could have went better? Yes. What could I have said? What could I have done? How could I have prepped? What could I have learned or reviewed that may have made that treatment or overall plan better for that patient? That's really helped me because it essentially sets me up for my next visit. And it's like you have that quiet time when you're driving or riding the train home or whatever it is, and you go through it, you box it up, and your brain will remember the next time you walk in that treatment room, like, okay, this is what I said I was going to do or what I needed to do. That's been huge for me. I still do it to this day.
Yeah, I love that. And I say all the time as well, look at your cases and your outcomes critically. And I mean critically. And not like you said, not just like they might look great. The smile might look great, but look critically. What could you have done even better? And when it doesn't look great or something isn't ideal, or maybe it looks great to the patient, but there's some compromises, what happened? We're all human. None of us are perfect at doing this. And I'm telling you, Vincenzo, that made me such a better provider for my patients because I would sit down with every single case at the end after a patient finished treatment. And I would call up on 2 different monitors, their initials and their finals. And I would look at them side by side on those monitors. And I would look at whether the 3D image, the side head view, the Panorex, the pictures, open bite pictures, and just look at the patient and say, what do I like here and what don't I like here? And when I started doing that, that's actually how I got on the whole Airway. Patients are breathing better because of what I'm doing trained, because I was like, whoa, wait a minute. Look what this just did to this patient. Let me start asking them some questions about this. And they'd come in for a Tainer check and I'd ask the parent like, hey, did you notice during treatment that, and yeah, actually, and that's because I was being critical. I could have just chalked it up. Yep. Next case, move on. You look great. I accomplished my objective. So that is something, being self-critical and a critical thinker, again, those common themes today, the diagnostics, the desire to not just treat symptoms and look at patients and get to the etiology. And then when you're done with that, be a critical thinker and evaluate your work. And sometimes it's not easy and sometimes it's not pretty, and that's okay. But if you just sit there and be like, well, they didn't wear their rubber bands in our world, or in your world, they didn't do their exercises. Well, maybe it is more than that. That might be true. And there's plenty of people that compliance is an issue. That being said, what could you have done differently? And maybe you could have scripted it differently to them. Maybe you could have chosen a different treatment approach, knowing they were a non-compliant patient if you took more time in the beginning, right? So I love that you said that because it's so important for providers. We can talk, we can get granular all we want on the ways we treat and the modalities we use and the techniques. At the end of the day, if you're not doing those 3 things, right? The diagnostics, the looking for and getting at the etiology and addressing that, and then being critical of your work, does it really even matter much? You're just mechanical at that point, right?
I agree. I think you said anyone can implement the techniques if they teach it, if they're taught long enough. It's like, especially that last part, it's like, okay, what did I miss? What did I didn't miss? How can it be better? And that's hard. That's not easy. People don't like to do that. And again, because they gotta criticize themselves.
Yeah.
Totally.
And then you got to do something about it on top of that, most likely, right? If you see it, then you got to, once you see it, right. Now it's like, and then you think of all the other cases you're in the middle of that you were doing with way A, and now you've got to do way B, and it's very overwhelming. It's like, I just want to stay in my little bubble, and you can easily rationalize it in your line of work or in mine. I'm still making the patient better. I mean, rarely are we in that moment making the patient worse. We can have arguments about long-term and all of that. But at that time, right, most of your patients, even if you're not delivering the best care, are getting are improving. Most of our patients are looking better as we're straightening their knee. Right. But if you just look at it as that's your metric and you don't look at what else, to me, you are not reaching your peak potential. And I can't tell you, I just said this on recent episodes too, a constant theme of people on this show that I'm impressed by the way they have broken down walls and barriers in their profession and are providing next level care to their patients. A constant theme is they are critical thinkers who are always willing to be self-reflective and do better for their patients, period. Like that is one underlying theme. And that is a standard 100% across the board. Yeah. And I don't think it's an accident.
No, I agree. And I think if you're a new clinician in any field, like this world is primed for that right now, because there's a lot of people who aren't doing that. And there's a ton of opportunity to just walk in anywhere and say, hey, I want to learn more, or I'm going to do my best to help this patient. And people know when you're giving them a different quality of service. They know.
Yes.
And they'll find out real soon where you are, because it comes off very genuine that you care to get them to a point that no one's attempted to get them.
Yes.
I'm still learning that, right? Like the service is so much more important. And I was more of a business conversation, but like the service is so much more important than, what you know, because no one cares what you know until they find out like, oh, this guy actually gives a shit about me,
Yep. Yeah. Caring. And we're so used to going to appointments and visits where that's not the case in all disciplines, not just in the medical arena, but those service experiences. But again, it's counterintuitive because you tend to want to get right to the treatment and get right to the doing. And that assessment, that patient assessment, that reading the room, that diagnostic, that communicating with other professionals is all done before you even really provide a billable service.
Yes.
But I really agree with you. What's going on now, the MAHA movement, and again, it's not even a political statement. We're talking about trying to improve the health of our society. People politicize it. This isn't political. This is about making us healthier. And we have trusted medicine and pharma, in my opinion, too much in a lot of regards. They've done a lot of wonderful things. I'm not saying they're evil in every aspect, but let's be honest. I think we would all hope that our physicians and our medical providers would take a little more time getting to know us and our bodies and our minds, and spending a little less time just throwing a drug at us or treating a symptom. Right. And you're doing that, and you're doing it effectively, and the proof is in your patients and the results that you get. So it's great. It's great you're doing it. And how can people reach you if they want to reach out to you, if they want to get in touch with you, learn more about Prime Physio?
Sure. You can look us up on Instagram. It's Prime Physio _. Trying to get on the whole Instagram / social media train and put out some more content. So you could find us there. You could also find us at our website, prime-physio.net. You can reach out to us. I'd say even just DM us. That's a good way to get in touch. And I always encourage people, there's not enough people doing this, so I'm happy to be that person, which is like, you have a question, just ask. Like, the answer is always no until you ask. And I'm happy to share knowledge with people to just help them go in the right direction, because this kind of goes on the whole medical system. It's like, it takes forever to get in touch with a doctor. It's like, no, I don't want to speak to the front desk person because they probably don't have the answer that I'm looking for. And if it's something that I think requires a deeper answer, I'll ask you to come in. But if I can answer it in a 2-second DM, I'm going to do it. It's just the right thing. And I think everybody should be doing that if they have the time and luxury to do it. That's how you can reach us.
Awesome.
And professionals too, like, hey, I got this case. What do you think? Yeah, let's talk about it. Let's get on a phone call.
No, I love that. So in other words, you have some people reach out, even if they're not in your area, you're saying, if they want to just consult with you. Okay.
I was talking to a therapist, a myofunctional therapist who's about an hour and a half north of here. And she's like, hey, I was like, send me the patient write-up, send me some images. I'll see what I can do to help you out based off of that. But at least it gets conversation going. We both learn, right? It's like, I get another patient I get to look at and learn something. And then she can also learn something from me and how I would maybe go through my stepwise approach. It's a win-win for both people. It's just the interest and the desire to get better has got to be there,
I love it. Dr. Vincenzo Recine, it's been absolutely awesome. A really, really fun conversation. I appreciate your openness, your honesty, your dedication to your patients. You're doing great stuff. And I really hope people hear this and think differently about the way we can approach patient care in general, but especially how we can coordinate care with physical therapy and dentistry to really get our patients to be healthier. And that's what it's all about at the end of the day. So thank you so much.
Of course. And thank you for, creating this platform and having me on to share my side of the story. And I hope your patients and your followers and the subscribers get some benefit out of this conversation.
Oh, I'm sure they will. I appreciate that very much. Been great getting to know you. Been great chatting with you. Thanks again.
Likewise, brother. Thank you.
All right. Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.